my talk.
Oh, this is nothing you
I mean, there's some things in there that I'm going to cover, but if you're going to try and follow that handout and what I say, you'll be hopelessly lost from probably slide 1. So it was just, I felt like I had to give you something, and actually even the one I was going to give you, I've interjected a lot of other concepts in this talk this morning, so it wouldn't follow very well either. So what this is just, you know, your file of accumulated papers on this and that. You can put it in that file. So the other thing is that the rules are, you know, jump in any time. I mean, this basically, I would like to work it like a discussion. I've set up enough slides. It's going to be, you know, probably non-stop chatter for me to get through it in an hour, but that's not my intention. That's not what we're here for. We're here to, you know, for everybody to get a common understanding. So that's what we need to arrive at. And my sense is that, you know, if we can get over this big mountain of information called evoked potentials and somatosensory evoked potentials, then we'll be doing great. And I think in the listing, what I was going to talk about today was called basic neurophysiology, and I'd be happy to lapse into, you know, membrane biophysics and sodium channels and potassium channels, but I think everybody knows that, and I don't think in terms of understanding evoked potentials that's really essential. So I'm sort of leapfrogging over that and going to say, understanding that you know, we've all got at least a rudimentary idea of what's going on at the membrane level, generating electrical fields around nerve cells and their axons, but we're going to sort of jump into the whole concept. Well, you all know who I am, of evoked potentials. And I think there's really two things that evoked potentials in general and somatosensory evoked potentials in particular try to do. And what they're basically doing is assessing the integrity of the sensory pathway. And I think that's pretty obvious, if, you know, for all of us that have had any association with these things. The other goal, which is not always as clear, particularly if you're talking with people that do visual evoked potentials, because they really don't get to, they assess the integrity, but they really don't get to identify the anatomical locus of the abnormality, because in evoked potentials, you stimulate at the eye, you record at the occiput, and that's about it. Brainstem auditory evoked potential people, they like to do this, but by the nature of the auditory pathway being so complex and so almost immediately bilateral, they can only do this in a rough sort of way. But people that are doing somatosensory evoked potentials, because the pathway is so long, and in that aspect it is unique. It's really, you know, one of the longest sensory pathways in the whole nervous system. And we have the ability to record potentials along, at certain selected points along that pathway, so we can really get into the idea of identifying the locus of an abnormality. And basically the way we do this, which you all, I'm sure, are familiar with, is we deliver a stimulus to a peripheral nerve or a sensory transducer. And I put this in here in thinking of SEPs, because one thing that people haven't done much is try to activate the sensory transducers, you know, with like air puff stimuli or things like that. But it's something that I think we here, as, you know, kind of thinking of a collection of great minds on this, might start thinking about this, even though we are just so apt to go right at it this way. We might want to think, is there something we can do with SEPs, get some you know, advantage, some power with evoked potentials by doing that. And then we record the response along the sensory pathway, and this is what I'm basically going to be talking to you about this morning, about the ramifications of that. Now, again, as I said, we usually use an electrical pulse to activate the somatosensory pathway. It's very interesting. Few people have used air puffs, and it you know, when you think about it, that could have a distinct advantage. These things hurt. This would just tickle. Okay, tapping and brushing is a little more problematic because, you know, you've got to do 300 iterations. By the time you whack somebody 300 times in one spot, it's, you know, that could be difficult. But this is an interesting concept, to use an air puff. Where I thought the idea would really be great is when you want to look at a trigeminal nerve. Delivering an electrical stimulus anywhere around the face is technically problematic, particularly the way our equipment is set up right now. But an air puff, there's no stimulus artifact. You know, it's pretty benign. You just sort of puff it on the tongue or puff it on the cheek or wherever you would like.
Stimulating all 5 receptors. Stimulating all 5 receptors, and that's fine.
Yeah, right, exactly. That's the only thing. But when it comes to recording something like that, you may have some problems doing that at the peripheral level, spinal cord level, the brainstem level. I'm sure you'd be able to do it at the cortical level. And we'll get into why we can record cortical signals to almost any stimulation that you can think of to deliver. But recordings from these levels is a little bit more problematic. Now, when it comes to the interpretation of these signals, what I feel one has to have a good understanding of is the generation of the electrical field in the tissue and the knowledge of the anatomical generators of these signals. You just can't go into this work without having a good feeling for these two concepts. And I hope by the end of the hour that we'll have given you a good idea, at least what my thinking is, on what that's all about. Now, let's start out with an understanding of the electrical field generation. There are two adjectives to the word potential that people have used. One is they've called them conducted potentials, meaning that the signal is conducted along a pathway, i.e. it's being conducted along axons of certain cell bodies within the sensory pathway. And the other is a field potential, and we'll get to that in a few moments. The conductive potential, as you may imagine, has a certain relationship to the action potential of the nerve fibers. And I'm sure you've all seen slides like this that show you, the schematic nerve or axon, in which we have up here that it's in the resting state with its inside negative. And then, for whatever reason, we start either by some injected current, by stimulation externally, or maybe if this would be where a receptor would be, then the activation through the receptor potential. And we start the influx of sodium that begins the regenerated action potential that, of course, is carried in both directions, and that's symbolized by our depolarized area starting small, getting larger, and getting larger. And we're all familiar with that concept. The thing that I just wanted to reiterate in everybody's mind is we have essentially two types of neurons in our sensory pathways. Those that are unmyelinated, and we see here that in this situation the action potential is just being generated continuously along the axon, with a little arrow here indicating its propagation from the cell body to the termination of the axon. And then there's our other type, which is the myelinated type. And although our graphic isn't very good, you can see that a myelinated axon in general is always larger than an unmyelinated axon. Now, some of the small myelinateds, in terms of the axon diameters, can get down to being fairly close, but the overall, including the myelin, it ends up being a much larger entity. And because of the myelination, the action potential, rather than being continuous as in the unmyelinated state, is saltatory, jumping from the internode to internode of the myelin. Now, the reason I brought that up is that when we're looking at what we're going to be doing is recording the electrical field that's external to these things. Like I said, I'm going to skip all that biophysics that goes along with the internal. And what we have to appreciate is that the size of the electrical field depends upon the size of the axon. The larger the size of the axon, the larger the electric field. But there is another factor, and that is the adjacent axons here, if they are inactive, they're going to shunt current. So depending on what type of axons and their sizes, and of course the number of them around our active unit, will determine how much current is shunted away from these individuals. And by shunting that current, then, what that means is the recorded signal gets smaller and smaller and smaller because the current gets shunted away.
If you had two axons of the same size, one myelinated, one unmyelinated, which one would have the larger field?
Myelinated. Yeah. And I could not find a slide of that, and what I'm going to do is try to get that and show it to you, or give you a handout of that next time. There's Boyd and Kalu actually worked up a way of calculating from the size of the axons and the number of axons what the compound action potential would look like. And if you look at Gasser and Graham actually originally did it, and if you look at the number of fibers with increasing fiber diameter, what you find is the distribution looks something like this, where these are all your small diameter, from unmyelinated to small myelinated, nobody can read my writing, up to the large myelinated fibers. And if you see in this distribution, you just have a huge number of unmyelinated fibers. This is peripheral nerve now. I think it's the median cutaneous nerve of the cat, if I remember correctly. And you just have a huge number of your unmyelinated fibers. But then if you would sort of superimpose on this the size of the compound action potential, where you're looking at your large myelinated, it would look something like that. And what this says is that these large diameter fibers contribute a huge portion to the overall compound action potential. The amount of signal that's generated by your small myelinated or unmyelinated fibers is really rather small. It bumps up here just because there's so many of them. But it gets into that whole idea of the size of the fiber determines the field.
What are you getting at with shunting?
Well, with shunting, let me just see if my next slide will maybe help with that a little bit. Not really. This was just going to give you... What I'm talking about with shunting is that I'm trying to think how I can do this without doing it mathematically for you. Basically what it says is that... Huh?
Math won't kill me.
Math won't kill you? It will me, because I'd have to recreate it. It's not something comes out of my mind. I got to laboriously work through it, and I'll be here all day. Which is why I like to think of these things this way. When you think of this, actually I know I've got a slide here in just a second. Hang on to that thought, and then we'll just get to that when we get here. Could I get a little focus on that, Bruce, perhaps?
What?
This is just a little fuzzy to my eyes at any rate. And anyway, what I want to just point out here is that also contributing to the size of these fibers and to this concept of shunting as well is the myelination around these large diameter fibers. And most of us probably think in terms of peripheral nerve and Schwann cells when it comes to myelin. And there recall that each single Schwann cell wraps itself around a certain segment of the fiber with these little nodes in between. You can see it trailing off there. In the central nervous system, it's very different. And this slide is nicely schematic in proportion. You see, here's the large diameter axons in peripheral nerve. When you get into the central nervous system, one thing that becomes immediately apparent is you can't cram all of those peripheral nerves into that little vertebral canal space. So the sizes of the fibers become smaller. The axons themselves do. And secondly, now the myelination is by the oligodendrocyte, but the oligodendrocyte serves several axons. And also, the amount of wrapping is not anywhere near the overall size. So when you get into CNS, same fiber out in PNS becomes smaller and in diameter, either in terms of axon or in the overall fiber itself.
How about node lengths?
That's a good question. I actually don't know the actual answer to that. I'm going to take a guesstimate based on photographs that I've seen, and these node lengths are closer together. Now, here's the slide that I was going to refer to in terms of the shunting. This one I'm sure you've probably all seen at some time or another. And I've been showing this for years, and I realize these little arrows are aimed wrong. They're supposed to be aimed the other way. But I don't even remember where I got this slide. Basically what this slide emphasizes is the fact that when the nerve fiber's at rest, we're recording extracellularly, we get no potential. Okay, that's pretty obvious, I think, to everybody. What I wanted to point out with this slide is what happens if we're recording at this point and our depolarization begins to approach the electrode. What we see is a little positivity that starts off, and that positivity is due to these local circuit currents that are part of that regenerating action potential propagating down the fiber. Once the depolarized region gets underneath the electrode, then our potential turns negative until it passes by, which is just passing by, so it's beginning to turn over, and then as it goes away, the trailing edge of the local circuit generates again a little positivity, and that's why we see the classic triphasic positive-negative positive potential that's associated with conducted potentials in which the signal is passing by your external recording electrode. Now, to answer your question, Skip, about shunting, what happens with these local currents that are occurring here is that they are all of the internal current is forced into the center of the core of the axon. The external current, on the other hand, and appreciate that the current is equal here, even though my arrows are sort of funny, the current is heading backwards in this direction, and the internal current is heading outward here. The current is equal in these two. Okay, if you think in terms of Ohm's law, and if you want to try and work through this, it does work. I've even tried it once way back. The current being equal, the voltage of the outside, the transmembrane current is the voltage of the outside minus the inside. And if you work that through, you see that the resistance is here. The resistance is going to be fixed in this case, but here the resistance is going to depend upon all this external stuff. And that becomes the shunting resistance, because the resistance between your recording electrodes is going to depend upon all this other tissue out here. If it's not active, it acts like a shunt. If the adjacent axon is active, then they're both going to be contributing voltage into that shunting space, and so it becomes proportional. If you have 1,000 fibers and they're all active, then your external electrode is going to see about half of the voltage that's across the membrane. If only 10% are active, it's going to drop off, 100 divided by 1900 so it drops off fairly precipitously because it's all being shunted. Does that make sense without doing the math for you?
Well, what you're really saying is you've got an external field.
Yeah, and it's what happens to that external field. That if adjacent ones are contributing into the external field, then the cumulative resistance here doesn't shunt it, you get a higher potential. Otherwise, if you have one, in a sense, yeah, it just gets shunted throughout all of the tissue, and when you're recording out here, you don't see it doesn't appear very large.
Current density at any one spot.
Yeah. So what's the bottom line here? Anytime you're recording externally, you're not going to see anything near the voltage that's occurring across the membrane. This will be in the terms of millivolts. You get out here, you start seeing in the terms of microvolts, because the current gets shunted into all of this external space.
Does also that mean that the response is not proportional to the number of axons, or it's not linear?
No, that is true, that it is.
The linear response to the number of axons?
I don't think it's quite linear. That's where I needed to get to that Boyd and Kalo article, which I didn't have yesterday, to check that.
If the external field somehow affects it, that the more you stimulate, the less the field might change that current. You might have a more, in other words, the response would go up, not linearly, but maybe exponentially.
In terms of the number of axons, right. If the axons are all the same diameter, I think it's going to be linear, if I remember correctly from the formula. The thing is that they're not. They're distributed, and so as you increase the stimulus intensity, you move from the larger to the smaller, but that isn't linear.
But these fields themselves are dependent on the resistance of tissues and geometry, and the geometry of the tissue. So where you measure a field externally is dependent on geometric factors.
Exactly. That gets into really a second issue of whether you're recording with an electrode sitting just outside here, or whether now you start recording with electrodes that are farther away and getting into a far field kind of concept. And that gets into what you're speaking of in terms of the
geometry.
geometry.
You're talking about really shunting lots of axons. You're talking about no longer being on a membrane. You're talking about being at some distance.
Yeah, you're talking about the whole nerve bundle itself. Yeah.
As soon as you talk about being at some distance, I mean, you bring in some characteristics of...
When you start talking, yeah, if you start talking, you're looking at this as being a nerve with a collection of fibers. If you're recording from this point, it's sort of what we've talked about up to now. Now what, Skip, you're talking about is if you start recording here, and now you're talking about a field here that's going to fall off as roughly the square of the distance. It's really the cube, but in the short terms that we look at, it's approximate to the square of the distance it falls off.
But I'm wondering, that field fall off at inversely proportional to the square of the distance in every direction. Because I'm just wondering, is that really true? Because the field is projected differently.
Yeah.
The orientation of your pickup electrode and where that generator is located.
Yeah, I'm gonna say yes, as long as you're in the homogeneous medium. But now, if you imagine this as a nerve inside of an arm, yeah, you're going to get to a boundary condition. As soon as you start when you think of the field is going to be kind of like this until it gets here, and then it's going to start doing this thing. Okay, so then you get into a boundary condition, and then that's when things start to change. And that's the deal with most far field stuff, is it's immediately confounded by the boundary conditions of, there's people that talk about this Erb's point potential as being really this change between the volume of the arm versus the volume of the trunk. People talked about potentials associated with the cervicomedullaries being the same issue with the head volume, neck, body volume type of thing. And that's really what this is all about, is the boundary condition. That's why even recording from the cortex itself, when you're doing direct recordings, you have the same problem, because you start getting the boundary, unless you dump the whole organism into a vat of physiological saline, and then you can have the field going out all over the place, and then it works. Okay, now that nice segue into field potentials themselves. And field potentials really are related to the synaptic potentials of a collection of neurons. That's what we're recording with our field potentials. And I just show this to remind everybody that cell bodies in the central nervous system are quite varied. The ones that we've just been talking about in terms of conduction potentials are generally associated with, like, the dorsal root ganglion cell, in which they are kind of a pseudo-unipolar, meaning that their cell body sits off to one side, in this case in the dorsal root ganglion, with a peripheral process that goes out to the skin and muscle, and that's what we've been talking about, is those conducting potentials there. But then, as I commented, as they get into the central nervous system, here meaning the posterior columns for the most part, their axons are really unlike this drawing. They actually get smaller, and of course they're myelinated by a different entity. The ones that I'm going to talk about in terms of field potentials in the central nervous system are more like those in which we have like a spinal motor neuron with a lot of dendritic processes going out in all different directions and an axon going somewhere. Maybe like the pyramidal cells that can be found either in the hippocampus or certainly in cerebral cortex, that have a fairly large cell body, basilar dendrites with usually a long apical dendrite that branches quite profusely. Hippocampals don't go very far. Cortical level cells tend to go several hundred microns to each side in these apical dendrites. May or may not have a lot of spines on them, meaning there's a lot of contact points for synaptic connections here. And then, of course, the classic wonderful dendritic arborization of the Purkinje cells of the cerebellum, which are, this is a little bit schematic, but they certainly are beautiful when you see them in fairly real-life type drawings. And what I'm emphasizing here is that these dendritic arborizations can have a lot of synaptic connections. And what we're talking about is a lot of field potentials for field potentials when we have those kind of synaptic connections. And what's happening here is the synapses, for the most part, are axodendritic, but we can't also forget that we do have axosomatic and even occasionally axoaxonic synapses. In terms of the fields, probably the axodendritics are the ones that are really creating most of the field of a synaptic barrage coming in upon a particular cell or collection of cells. But this cannot be discounted. I don't know that we're in an overall field, the overall picture, we're going to see that much, out of this character here. Now, what you also have to remember is, okay, we're having synaptic connections, but those connections can either be excitatory or they can be inhibitory. As kind of a general rule, at least in cortex, also in the cerebellum and some other places, excitatory connections are thought to be are mostly out on the dendrites, with the inhibitory ones closer to the cell body. And what some folks like Gordon Shepard, others have thought about is that really gives a certain power to the inhibitory input, because it's down here able to take any current that is coming down from the excitatory synaptic field and shunt it off very quickly. And so the inhibitory connections can very effectively stop the initiation of an action potential. But, you know, all of that kind of tucked back in your mind. The thing that you have to realize is that all of these synaptic connections, be they excitatory or be they inhibitory, are starting to create an electrical field. And what we see here is the current being drawn out at this point. You can connect the dots here and bring the field around, and we have the current entering from the rest of the cell body. An excitatory connection, it's entering here at this point, but it's then exiting. And so each neuron, when it starts to receive a synaptic barrage, and by that I'm sort of translating that in somatosensory evoked potentials, we've stimulated out here and we've sent a barrage of impulses in over a collection of nerve fibers, and they're starting to make synaptic connections first in the spinal cord, then they'll make them in the brainstem level, thalamus, and then cortex. And this kind of field potential is being set up every time one of those synaptic events are occurring. Now, Laurent Denouet, years ago, came up with this scheme, and it's been repeated in every textbook since, and I guess that's because no one has really come up with a different type of a model. He proposed that you have three types of systems: an open field, a closed field, or a combination open and closed field. And what we have here is the schematic of the cell bodies and the alignments of their processes, dendritic and axonal. In this case, you can see that they are all nicely parallel and they're all lined up. And what you can imagine is if you have, as we were just pointing out a moment ago, the electric field formed by synaptic connectivity sort of flowing in this kind of an arrangement, you can see that each one of these is going to summate together because they're all going to be working parallel and in concert. And so the electric fields here are going to form a nice cumulative effect that will give you an overall, I'm searching for the term, an overall type of dipole that will give you a positivity at one end and a negativity of the other as a result of the electric field in the collection of neurons. For a closed system, the cell bodies have processes that are heading off in different directions. This is almost shown in a random type fashion. I don't think it will take too much of your imagination to see that when these are depolarized, that the overall electric field ends up being kind of circular and the collection ends up being random, so that as seen from the outside there is no consistent electric field. If you look inside and you record from the neuron itself, yes, you're going to see its field around that neuron. But when we're looking at it from the outside with an electrode out here, you just don't see it because there isn't each field of each cell cancels out its neighbor, so to speak, and there is no overall electric field. This situation is very much like cerebral cortex. The pyramidal cell that I just showed a slide ago with its apical dendrite is like this. This situation is very characteristic of thalamus, which is why we're able to put single cell recording electrodes in thalamus, record their action potentials very, very nicely, isolate where the ventralis caudalis or sensory nucleus is in the thalamus compared to ventral intermediate nucleus, find out where we're supposed to put electrodes in for controlling tremor. It's no problem. But if I were to try to do that with an evoked potential mechanism, impossible, because the thalamus doesn't generate this consistent electrical field that can be seen outside the thalamus. And so any article you're reading which somebody's claiming that they're recording a little wavelet on the evoked potential that is generated by the thalamus, I'm always very skeptical. I mean, I'm not saying it's impossible. It can happen because there's parts of the thalamus that do have more kind of this open-closed field, and maybe one can do it. But nobody has really consistently been able to demonstrate that. Similarly, the open and closed being a combination of the two, gives you some electrical field that can be seen from outside, and this is probably most typical of the dorsal column nuclei. And various people say that some of the waveforms that we cursor and we label are generated by the dorsal column nuclei. Other people say no, that's probably not so true. It's really coming from the fiber pathways associated with the input, i.e. posterior columns, or the output, medial lemniscus, of the dorsal column nuclei. Okay. As I said a while ago, the uniqueness of the somatosensory evoked potential in the somatosensory system is that we can record them from different levels. And what I'd like to do now is just briefly go through what we can see at the at each level of the system. And let's begin with the peripheral nerve. Typically for our mixed nerves, we use the tibial nerve stimulated at the ankle and record at the popliteal fossa. And if I show you this potential here, right down at the bottom, nice red arrow identifying it, you see that this is a compound nerve action potential stimulating here at the ankle, recording at the popliteal fossa, and it has that kind of triphasic positive, negative, positive waveform that is typical of the compound action potentials that we were talking about just a little bit ago. And this signal is very useful because it gives you an indication of the conduction in the peripheral nerve. One has a recording and a latency that one can measure. You can also measure the distance, do your division, and you have a conduction velocity, so you can get a rough estimate with the SEP of what the peripheral conduction is in an individual. Similarly, we can do the recordings along the arm for the stimulating the median nerve, and they can be recorded either at the elbow, the axilla at Erb's point. Erb's point is the classic place of recording. Over the years, people have done Erb's point. I ran into some problems with Erb's point with regard to ulnar nerve stimulation. I mean, it's true with median. You can, in just about everybody, you can get an Erb's point, but not always. You know, people that are normal peripherally, can you always get an Erb's point? And so what I did is switch the electrodes down to the upper arm, and kind of define this as 30 centimeters from the midline with the arm held 90 degrees abducted. And the nice thing about this, if you go between the bicep and tricep muscles, is there lies both your median, your ulnar nerve cozy together, and you can get a really, in all cases, a larger response than you get at Erb's point, and you can nearly always, if not always, get one to the ulnar nerves that record at that point. Yeah,
What kind of recording montage do you use at the axilla? Is it a monopole recording? Is your reference?
Yeah. The reference is just up here on the over the deltoid, somewhere up there, and it gives you again, it's a pretty classic triphasic. So it's this one. Ends up being somewhat often a biphasic looking potential, and that may be because the one seeing it this way, we usually refer it to the opposite side, and so that one's really seeing some of it. So it's like a classic, two leads along a fiber in which you're getting the biphasic potential as opposed to a true mono kind of consideration. And the other thing I like about this is, outstretched, you get a nice clean measure of the distance. You know where it's being generated by the signal passing under this. Get to this discussion about the Erb's point, about where is Erb's point really generated, is it at the electrode or is it at the junction here? Then I always say, well, measuring that distance and doing my division for the conduction velocity might be slightly in error, but this one would have no error component in it because it's being generated right underneath the electrode, the recording electrode. Once we get the signal past the peripheral nerve and start into the spinal cord, then it starts becoming a little bit more complicated, and that is because in the spinal cord we can record both field potentials generated within the dorsal horn, and we can record conduction potentials from the posterior columns. However, let me just say this, and I will kind of come back to this a couple of times. Recording the conductive potentials in the posterior columns is not an easy proposition. And it's one that I think that people in sort of starting out think that, well, one can do that, and it's just very easy to put electrodes along the spine and record the conductive potential. And for the reasons that we've talked about, shunting currents, sizes of fibers, and a couple of other considerations, that makes this a not very easy proposition. I put this one in here so I wouldn't forget to mention this. As we think about the fibers coming in over the dorsal roots and coming into the spinal cord, we always must remember this anatomical fact, and that is that the nerve rootlets, contrary to drawings in textbooks, don't go through the neural foramen straight into the spinal cord and enter at the vertebral level, the bony vertebral level. They almost always, in almost every individual, ascend a certain amount. And you can see these in the cervical spinal cord. Here's our floor of the fourth ventricle, cervical cord, first, second, third, fourth, fifth nerve root, and you can see these coming in. They dorsal root ganglion is going to be right about here, and these are streaming up, and you can see that some of them can get up one level. In some cases, they can even get two vertebral levels above their entry point. And so if you're trying to again, understanding relating your signals to the generation, orthopedic people will be talking about vertebral level. We have to remember, if you're talking about a problem here you've diagnosed, you're really talking in the spinal cord, you're talking about its dorsal root entry zone. And that can be anywhere from 1 to 2 levels above where they enter. And so there can often be a dissociation between one's anatomical locus based on EPs and anatomic radiographic locus based on what orthopedic people like to do. And you always have to remember that. Now, once these signals do enter into you see how they always just draw them, right, straight in like this, and never give them a chance to go up. But once the fibers enter the spinal cord, they're going to do one of two things. They're either going to enter as the large diameter fibers do, as indicated here. And large diameter fibers tend to go clear across and enter the spinal cord medially, and then they will turn up and go up in the posterior columns. The small diameter fibers, on the other hand, will enter the spinal cord more laterally. It will come into the dorsal horn, and there they're going to synapse. And through either mono or polysynaptic connections, they're going to activate the cell bodies or the originators of the anterolateral pathway, either ascending in the ventral spinal thalamic or crossing completely over and ascending in the lateral spinal thalamic pathways. Large diameter fibers in this drawing are indicated going in here. Don't forget that large diameter fibers often branch, and like they are shown here, some of them will even branch and come clear down and form monosynaptic connections on our anterior horn cells. Those, of course, are for our monosynaptic reflexes like the stretch reflex. Others will come in here, synapse, form polysynaptic connections, again for reflex activity here. And some will come in synapse in the dorsal horn and like one of these yellow fellows here, and they will also ascend in this one being in Clark's column, or they may come out and head up in the spinal cervical tracts that are in the lateral funiculus here. Now, this whole arrangement here is really prime for generating nice field potentials. And I've put this one on just because I think this is a beautiful drawing that Santagatai and Retelier made many years ago. But this is their conceptualization based on their anatomical studies of the spinal cord. And what I just wanted to kind of point out, which wasn't quite shown in the last one, is this arrangement in the dorsal horn of kind of layers of cells in their dendritic processes going up into the upper layers of the dorsal horn. All of these, as I said, can receive inputs from peripheral nerves. And here we have this nice arrangement. We're starting to get cell bodies and their processes all aimed up this way. They're all aimed in a nice parallel fashion.
These are the various lamina.
These are the various lamina, yeah. Santagatai, he doesn't quite buy into Rexid's lamination. Kind of depends on whether you're a cat person or a monkey person. Rexid was cat, and so he labeled the 1 through 11, or 11 layers in the cat, and you see the 1 through 4 here, and 9. He even skips 10 and 11 in Santagatai. Santagatai and Kuipers used monkey, and what they basically came up with was this kind of central core concept, which is the intermediate zone, the layers from 5 through about 8 of Rexid. And they really like this core because you get propiospinal connections back and forth. They also, like I said, identified these cells that have their processes that go up into the upper layers. And my point is that all of this gives you a nice neuropill that is just a good basis for generating an electric field. And so, for that reason, when one puts electrodes over the dorsal root entry zone, in this case a cervical enlargement for stimulating the median nerve, what one sees is a very prominent overall negative envelope here, and most of this envelope is generated by that neuropill, by the dorsal horn. What one sees sometimes, and this one has this little notch on it here, there are sometimes little notches on the rising side, and there's also sometimes a little notch on the falling side. And those notches are And I'm almost 95%, even if, depending on a good day, I'll go up to 99% certain that those notches are generated by the conductive potentials coming in on the dorsal roots. What I don't know in my mind is whether it's the dorsal root outside, at, or inside the foramen. The junction between the Schwann cell myelization and oligodendrocyte myelization occurs right there in a kind of a graded fashion. It's not a nice line, but it happens at the neural foramen. And one of the things that I haven't found, confessing that I haven't really looked really hard in old literature, which is hard to access without Medline, because we don't go back that far, is people that ever recorded right along to tell me what happens to the potential. Because I'm sure that it's going to change in size and character a little bit as you get from that different myelization. So I don't know, this may actually be coming mostly outside where it's really Schwann cell myelization, where I would figure that it's large diameter and a large field, and that you're going to lose it when you get on the inside with the oligodendrocyte myelization. But that's a hypothesis, that's not a statement of fact. If we look at the lumbar level for stimulating tibial nerve, we can also record nice potentials over the lumbar enlargement. And I should say that people have put an array of electrodes on here and looked at the amplitude of the response as a function of the distance along the axial line. And for both the cervical and the lumbar levels, you see what's kind of indicated here is a point at which you have a peak in the size of the potential. And that, in both cases, corresponds nicely to where the dorsal root entry zones is for median and tibial nerve, respectively. And so these potentials are fairly large, but it gets back to what Skip was saying earlier about the sort of the overall dynamics. If you have this potential generated at the spinal cord, and the larger the person is, the farther your electrode is away, and so you get that decrease. So large people give you small potentials, skinny people will give you the large potentials. And so when you're faced with an individual that you're trying to record these, you have to think always of the body habitus to interpret your findings. And these potentials are probably better interpreted as their presence as opposed to their absence, unless you're really convinced that person should have generated, you should have been able to record one easily to say that it's an absent response and that is significant.
Jeff, the T12, L2, and L4s are usually about the same latency. I mean, they're very close. Same generator.
Yeah. Actually, what George is bringing up is a concept now, which is, I'm referring to these in the sense of the field potential, but the question is, what about the conductive potential? And that, as I mentioned a while ago, that conductive potential along the spinal cord is difficult. The potential at L4 tends to have a little shorter latency. You can see it here. There's a little. This latency is less than the one up here, and probably what you're seeing at the takeoff here is the activity that's coming again into the spinal cord. Whether it's where it is exactly in terms of the foramen inside or out, or whether it's truly a cauda equina, I think I'd like to see some more study on that, but certainly one can look at this part of it as being the conducted portion that's coming into the spinal cord. You usually see this as having this kind of notch configuration if you get a nice clean recording like this, which happens how many times, George? 1 in 100?
Never seen one.
Yeah, I've never seen one, that's true. This is probably some skinny little kid I did to do this. This part usually has the same latency as what you're seeing at L4 and T12. And that's how most people determine what is the field, or some people use the term standing potential versus the conducted or traveling wave, is whether they have a consistent latency or whether the latency should move later and later as you come up the spinal cord. The conducted portion, the traveling wave, just gets buried in the size of these signals. It's in there somewhere, but you just don't see it. I've even done this in monkeys, which are really skinny, and if you're really good, you can see a little notch sometimes, but that's about all. So you really are not seeing the traveling component in these. But once you get up to about the T10 level, now you can see two things have happened. The signal has gotten very, very small, but also the latency has now started to shift a little bit later, both in terms of the onset and the peak. And probably when you're getting to T10, you're starting to see a conducted portion.
If you're using a needle electrode to pick up, can you always get the signal from the L4 spine for the normal subject?
No, because we do it in the operating room. That's how we record these things, and you don't always get it. And Walter and I tried that years ago. We subjected some people to needles, and A, that's not a lot of fun, and B, it's not always profitable. So it would not be a way that I would advocate. I would choose that method only if you just absolutely have to have that information to make a critical decision. But even then, absence of signal has got to be used cautiously to mean there is really no response, and it's indicative of some kind of pathology or interpretation of pathology. Because even in the operating room, I could show you records. And the thing is that it gets back to this whole concept of the size of these fibers, the fact that when you're in the peripheral nerve, when you're stimulating the peripheral nerve, nearly all of the bundle is going to be depolarized. But when you start getting into the canal here, by definition, you're coming in over one or two roots, and you have all of the fibers from all of the other roots that you didn't activate. And so you have a great shunting going on. As soon as you get into the vertebral canal, that whole shunting principle increases. And so that means that the size of the signal is going to be reduced. And that's why I'm saying, from my concept of where I'm saying these things are, I really think that probably it's coming more from outside the foramen, where you don't have so much of that shunting principle involved. And so these signals become very, very tiny. And then, topographically organized, I think we all know that, okay. Ta-da. The only thing I just might point out is that the signals that we're looking at are generated from the posterior columns. You soft cell, we go right by what's happening from the anterolateral pathway, but in terms of the potentials that we're recording, this is a non-contributor. And part of that, again, is because it's hard to activate those guys. They're pain and temperature, and they're small diameter, and we usually don't use the intensities required to even activate these fibers. But even if they are really small diameter, and they don't contribute much to the overall potential. So all these potentials we're talking about, including that is going to be generated from cortex, is all out of the posterior columns, and they always have to remember the collection of modalities that are associated with that when you start thinking of what your clinical picture is in relationship to the evoked potentials. Here was the other factor that makes conducted potentials in the spinal cord extremely difficult. This is a slide from, as you can see, quite some time ago. In fact, it's so long ago I can't remember who did the work now, because I forgot to write it on the slide. But what this is a sections through the spinal cord of a human who had a lumbosacral spinal cord injury. And it's a myelin stain, and what you're seeing is that the myelin, of course, is present in the other pathways, but not in the posterior columns, because they have degenerated as a result of the injury. These are all, you can see some degeneration down here in your lateral spinal thalamic pathway, but all the descending pathways here, of course, are still intact, and so they're showing up nicely in black. The key thing is here, there's really two key things. One is that as we come up the spinal cord from our low thoracic, mid thoracic, high thoracic, you can see that the overall area here gets smaller and smaller. And the reason for that is that the posterior column fibers are breaking off and going into the spinal cord. I forget exactly the numbers now, but somebody painstakingly measured this, and you lose probably somewhere between 1/3 and 50% of the fibers. So, even if you lose them, they go into the spinal cord. What's happening is they're coming off the posterior columns and going into the spinal cord progressively as you come up. So you start out with 1,000 fibers down here, and you end up with about 600 of them by the time you get up to the cervical level. You can see even the cervical, they get smaller still.
Where do they end up?
They go into the spinal cord and make synaptic contact in the spinal cord.
In the gray?
And these are in the spinal gray. And these are not true propriospinal, but they are forming intraspinal connections. And so in that sense, they are propriospinal. What that means is that the electrical field is going to be of some size here, and it's going to be a fraction of that size just by virtue of the fact there are not as many fibers. Plus, we don't know who's being activated and not, so we don't know what the difference in shunting is between these two levels as well. The other thing that is to be pointed out here is as you begin to come up, you see that over here, here's the septum between the posterior columns in the rest of the spinal cord. You see, as we come up, we start to collect fibers, and these are the lateral, in the lateral position, those that are associated with the thoracic, and ultimately up here with the inputs from the arm. And they sort of push the lower extremity into the center, with the sacral, of course, located down here at the bottom.
Jeff, can you ever record a potential to the spine, the cervical spine, and the tibial nerve stimulation?
Well, you can, but its amplitude even with a needle, and this is taking up from our data from the operating room, is about 0.2 microvolts. That's with the needle down on the lamina. So by the time you take your electrode out to the skin, it's not going to be any bigger. If anything, it's going to be smaller. So it's really very difficult. I know that when I've done this is in situations where knowing the level was extremely important. I've usually done it in cases like transverse myelitis, where you're really trying to decide is the distal part of the cord working or not working. I mean, there's no question there's a block at the thoracic level. What I've done is stimulated the tibial nerve bilaterally. By doing that, we're doubling the number of fibers, and we're hopefully getting away from a little bit, we're getting a bigger signal. And record with a series of electrodes that are placed right up the spine, about 3 or 4 centimeters apart. And in individuals, which is a true transverse myelitis, you're going to get that large lumbar potential that I showed a moment ago, and you actually can track. You've got to do like 4,000 sweeps times 3 runs, do a grand average on all of them. Everything has to be perfectly quiet, beautiful contact, low impedances, optimal recording conditions. And you can record them, and you can actually track, and I've done that a couple of times, been able to track and see the block.
And actually,
but,
something I would like to have done in some of the MS patients, to determine where the lesions are.
Right, to get the level, and also, like I say, if the person is at least in the early stages, like in transverse myelitis, they're completely flaccid, and you're wondering, is this the full cord drain? I mean, I think it has prognostic implications if you know that the cord is functioning below. So it can be done, but it's not easy. And I say that usually we think, oh, we can just record these things right on up the system, but because of these biophysical reasons, it's very difficult to do so.
Is that what people call electrospinogram? I mean, the term electrospinogram.
Oh yeah, that's right. I'd forgotten that term. That was what's his name? Ertekin. I'm not even sure of the pronunciation, but he was from Turkey, and he had the electrospinogram, and he actually did it with needles which he would put intrathecally. he would stick a whole line of them and take those needles right into the canal. Ooh, it gave me the shivers when I read it. Okay, we're at 8. Do people have to go, or can we got to? Yeah, I should be able to finish in 10. Next level is our brainstem level, and here I have to waffle a little bit, and that's why I use the term probably combination of conducted and field potentials, more waffling, near and or immediately above the cervicomedullary junction. And part of the reason for all of the waffling is that no one has really has had the advantage of doing the kind of studies you need to do to determine where these signals really come from. You take it as a collection of what people have done, and I just can't come up with a solid reason. In fact, I thought my whole concept was taken apart the other day in the operating room, but then fortunately the person had a brachial plexopathy instead of a cord injury, so I was okay. I still can say that where I think these signals come from is here at the cervicomedullary junction. And the way we set it up,
Can I ask you just to drop back down, because you've got that cervical potential that you're recording. Now you're recording that cervical. Where's your active? Where are you picking that up from?
Oh, it's picked up with an electrode over the C7 spinous process.
Well, you can record a potential of that same morphology from way up at C2.
That's true.
Okay.
That's true.
It looks just like that.
Just like that guy.
Exactly like that. It has that notch in it.
Yep.
And you commented that the peak of that notch was in dorsal horn.
Yep.
And there's just a lot of discussion in literature as to whether that was contributed from the cervicomedullary junction. for instance, by the
Oh, yeah.
the nuclei up there.
Yep.
And have you decided that's not the case?
I don't think that's the case. I don't think that, I think that if you're looking at C2, I'm guessing that there is probably a contribution to this overall waveform that's coming from the dorsal column nuclei. I won't say that there is not, but I'm not.
Waffle.
It's a waffle. That's right. My point is that if you look at the people that tried to do the latencies, I mean they came up with a little bit of a shift, and they say that shift, if you calculate the distance and do your conduction velocities, that it's all appropriate. But when you really try to do it, if you put two leads on there, it is really hard to see a difference in the latency between what you record at C7 and what you record at C2. The other thing is, I'm going back on the anatomy of the dorsal column nuclei. They're just not that greatly set up to give you a very big potential, not like the dorsal horn is. The other thing is, I've said put the electrode on C7, and I'm doing that so you can kind of do ulnar and median nerve at the same time. You have to remember that median nerve people, they're going in on C6 and C7, but they're not going straight in. They go up. And the dorsal root entry zone for median nerves in this collection of people, I'm going to guess, could be anywhere from C3 down to C6. And if you have and you don't have to have very many fibers going in, you see now you start getting a potential that's being distributed over a length of spinal cord, maybe as far up as C3. And people that are putting the C2 electrode on is probably not so much really over C2, they're probably really over C3. So I don't. The thing is, what people need to do is have an open cervical-medullary junction and have recording electrodes right on the spinal cord. And that you can do, but not all neurosurgeons let you do these kind of recordings.
You're going to propose here, I see that what you're calling your brainstem potential is really from a different generator and not simply a far field.
That's right.
Of that lower potential.
You got exactly where I'm going. This potential, which we record in such a way so that it becomes a positive waveform, just to nicely distinguish it from the negative waveform of the cervical, is separately generated. And probably the best evidence for that, and I didn't slip that slide in here because I didn't have it available yesterday when I was putting these together, is data from Moger in France, in Lyon, in which he had a patient with who'd gone to a chiropractor and had after one of those adjustment things, had a bone spicule that went through half of the cervical-medullary junction, leaving one half intact and the other half completely transected. And what he found on the input from the intact side is he had both of these signals. On the injured side, this signal was exactly the same as its contralateral counterpart. This one was absent, and of course the cortical was absent. And that probably is the cleanest set of data that's in the literature. Anything else that you read that says, oh no, these are both generated in the cervical cord or they're both generated in the cervical medullary, are all tumor. And tumors just, you know, you don't know quite where all the lesion effects are. And so I always fall back, even though it's an N of 1. Moger since then had somebody else that was similar but not quite as nice. Huh? You have volunteers to have an adjustment.
Brainstem you're recording over the mastoid.
We record it from the mastoid. It's actually an FZ referred to mastoid montage. FZ to mastoid, and doing it that way gives it the positive configuration.
So you're measuring at far field.
Yeah.
Pretty far away from it.
Yeah.
Your C7 active electrode, your reference to FC.
Yeah, most of the time. If you use, well, yeah, I can. You can reference it. We usually reference it to FZ, and it ends up being nice and large that way. Yes, it's confounded because FC is seeing everything else that's happening in the brainstem and adds to it, and that's okay for the most part. If you really want to be able to distinguish these two, it's probably best to take the CZ and refer it either off to the shoulder or, as George was just saying, to the pretracheal. That gives you a little bit more, quote, cleaner cervical potential. The difficulty is that you eliminate your FZ contribution, and so it gets smaller. And most of the time when you start looking at it, you don't like that little tiny little size. And so, you know, But to really be a pure cervical, one needs to take that reference away from FZ, because FZ sees some of this as well that's coming through the brainstem, because it's sitting up here and it's seeing everything that's approaching along the neuraxis. And any signal that's coming towards an electrode will give you that positive potential. And with the FZ as a reference here, even though it's positive to the FZ because it's in the referential position, that inverts it and it adds to the negativity that's being seen by the cervical lead. If everybody followed that reasoning, and so it contributes to this. Any other questions? Now, one might say, why, given all of this discussion about where does it really come from, and is it easy to record and so on, why would one do this? Well, one of the things is just to remember the anatomy, and that is that our pathway, so far we've talked about the posterior column fibers that have come up, they've synapsed here in the dorsal column nuclei, and the fibers, the second order fibers, exit the dorsal column nuclei and almost immediately start to cross over. And they form the medial lemniscus that ascends through the brainstem to the thalamus, where we have our synapse and the third order fibers, which are going to go on up to cerebral cortex. The brainstem level potential, if it is indeed coming from here, and nearly everybody agrees it's somewhere down in this region, the lower brainstem. We'll quibble about whether we're at which side of the dorsal column nuclei. That's kind of that's an academic issue. The clinical practical issue is that we know that these potentials are coming down from here, so they are useful to tell us what's happening to the signal as it's immediately coming up in the medial lemniscus. And one has to remember that the medial lemniscus does a very interesting thing. In the lower part of the brainstem, it's located almost on the midline. As we come up to the midbrain, it rotates and becomes instead of a more vertical type structure, it becomes a horizontal structure that starts to come across like this. And part of that is because now we've picked up the trigeminal nerve, and its contributions have come in as well in here. So this has gotten to be a little bit bigger structure, now having the face input added to everything else. But here's what's interesting about this and some interpretations. If you're looking down at the medullary level, here's our medial lemniscus. It's on the midline, and it's a vertically oriented in terms of its longer length. Topographically, face is on the top, head is on the top, arms with the legs down at the bottom. Which means if you're doing median and tibial nerves and you're looking for a problem here, and you have a problem with the tibial nerve, and you don't have a problem with the arm, and you really think it's down this low, then it's because your problem is like a clival meningioma that's pressing up from the bottom, and you really ought to have a patient with long tract signs, because you have to go through your corticospinal pathways here in the pyramids in order to get to anything with the leg. You'd have to have a fairly involved in order to get clear up to where the arms are, because they're buried more centrally in the overall medulla. When you get up to the midbrain, the medial lemniscus is rotated out. It's more of a horizontal structure, and you see our individual here has just decided to take it easy, and now our head is placed medially, arms with the legs laterally. Now, here's another thing that this can be used for. If you have vascular lesions, which can happen with the branches off the vertebral artery and interruption of perforating arteries that are going into the brainstem, if the interruption is lateral, then depending upon the level, whether you're down low at the bulb or whether you're up higher in the midbrain, you're going to affect the leg pathway at the midbrain level, or you won't affect either one of them if you're down at the level of the bulb. So a lateral infarction, which could give you, a Horner's syndrome, you could have some dysphagia, dysarthria, you can all the things associated with these tracts out here, but you should have intact medial lemniscal function. If it's more medial, lower down, it'll get the medial lemniscus, both the arm and the leg, Or if it's up at the midbrain, it's going to get the arm, but it won't get the leg pathway because it's out here in the lateral portion. Okay, now in just the last couple of minutes, let's focus a little bit on the cortically generated signal. It's generated in the postcentral gyrus, and I show you this because no one can ever determine where the postcentral gyrus is. I always have fun with the surgeons in the operating room when we're trying to do this. We play this guessing game of where is it, and everybody points to their favorite gyrus when you're only looking at maybe this much of it. And then we go do the studies and find out where it really is, and half the time no one's correct because you really can't tell. Brodmann was nice enough to label things for us, and I bring this up just to mention that there are different cytoarchitectonic areas where what we're really interested in are areas 1, 2, and 3 on the postcentral gyrus. This is the tissue that is generating the signal that we call the somatosensory evoked potential. And this area is also topographically organized, and I probably don't need to tell you this, but just to remind you that the legs are medial, the arms are lateral, and if you're looking at face, if you're doing trigeminals, you have to move your electrode a little bit farther lateral still because the face is positioned even more lateral. Somebody's really excavating there.
Can you do facial SEPs? I mean, or is it too close to the...
You can. It's technically it's difficult. Yeah, technically difficult. Okay, the signals that we record to the upper extremity, and that's not only the median but also the ulnar nerve, and even the dermatomal stimulation of the fingers, gives you this type of morphology, where you have an initially negative potential followed by a positive potential that may have even a couple of notches or a couple of components to it. And that's the very classically recorded, either with a reference at FZ or even with a reference at the mastoid or off on the shoulder. It still has that general waveform. And that, of course, is recorded laterally over the topographically focal area for the upper extremities. The tibial nerve signal, recorded off the midline, is more the W shape. Very seldom has any kind of negativity to it. It's usually just an onset that goes into a positive potential followed by a negative, positive, negative elaboration. This type of waveform is typical of every dermatome except the fingers. And we can talk about that at some other time, as what the significance of that is. It's interesting, but that's kind of the way things are. My last point is going to be the orientation of the electric field. And this, I think, is very, very important when we're doing tibial nerve SEPs. Remember that our cortical cytoarchitectonics gives us these pyramidal cells with their long apical dendrites. They actually branch more than indicated in the drawing here. And they're all lined up so they give us this nice collection. So we have a dipole that is going to be oriented normal to the surface of the cortex. Not necessarily the surface of the brain or the skull, but the surface of the cortex. What you have to remember with your tibial nerve, as I just said a moment ago, that topographically it is the focal area is towards the midline. If the activated neurons are, as they're indicated here, sort of still up on the exposed surface of the brain, the dipole is going to point pretty much to the midline, and that's where people over the years have classically said that the evoked potential should be generated, right here on the midline. But not everyone has their topographical focus exactly in that position. If we look at the data from Woolsey, which was done in humans, recording and stimulating from exposed cortex, you find that this guinea right here, the bend of the cortex, could be topographically the toes in one individual up to the hip in another individual. And what that means is many people put their feet down on the mesial wall, which starts to turn the surface of the cortex over into this position, which means that our dipole is now rotating around and becoming more horizontal. And what that means is the signal then is going to be recorded, because it's recorded maximally at the extreme of the dipole, and it will be recorded off to one side in a parasagittal position. Now this is sometimes referred to as paradoxical because you see that the side it's recorded on is going to be the same side as the stimulation. But it's not that the signal is generated in the ipsilateral hemisphere, it's still generated in the contralateral hemisphere. It's just a ramification of the orientation of the electric field that gives you this kind of a configuration. And this probably happens, I would say, 15% of the time at least, if not more. What can happen in the extreme is this dipole sometimes will get so far turned around that you're not going to be able to see the potential in the classic W pattern, but you then begin to start recording it from the other end of the dipole, and what you see then is either at the midline or contralaterally an inverted potential, so it's this one as if it's just been turned over. And those situations occur much less frequently. I'm going to guess like 2% of the time.
We've got one classic case for that woman.
Yeah, we've had actually several classic cases. And
Explain why it's inverted, again, why it becomes inverted then.
because the dipole, this tissue starts to fold, and you know this is obviously very schematic, but it gets folded so far it goes underneath, so the dipole continues on around, and you're looking at it from the bottom end of it, and then the potential just inverts.
Jeff, that changes can potentially change your amplitudes a lot. How much will it change your latency?
That's the key thing. It really doesn't change the latency a lot unless you're recording it kind of like this guy. If you start to record around here instead of at the end of it, then what can happen is as you are going around here, it doesn't just sort of stay the W, and then flip over and get smaller and smaller. You actually start getting a little negative thing starting to occur. And then latency interpretation can be confounded because you're not sure where to take it, from the onset of it or from the peak. And I usually fall back to going to the onset. If it really looks like a kind of an atypical morphology, it's probably best to go to the onset. I don't think the onset's going to change because that should tell you when things are arriving at the cortex. What's happening after that in terms of trying to pick the correct
But the problem
P1
is
peak?
you record from the peak, and so it changes the peak.
Yeah, and the peak does some funny things, and I've even done some where, when you record through the cortex with an electrode that's being penetrated through the cortex, you get the same reversal because the generation is kind of here in the mid layers, and so as you go through, the potential inverts. In other words, you just record like you're going right along that dipole. And you would think it should just sort of get smaller and then flip over, and it doesn't do that. The peaks sort of move back and forth. And if you have a nice one like this, and you start recording all the way across over here to get it to turn over, it doesn't just turn over. The same thing happens, people talk about recording the phase reversal as you record across the central sulcus. And we do this routinely in the operating room, and I'll probably show you some examples of this in a few weeks when I do that. But if you're looking at the central sulcus here, and you record in a series of electrodes across here, well, they do this sort of thing, and then they turn over. They go from being a negative to being a positive wave. Okay, but the same thing, if you really look at these, they don't just turn over. Right in the middle, the peaks start changing latencies. And I'm sure if I had the rights to do it, I could figure that out by doing the mathematical modeling of electric fields. But it's just something in the biophysics of an electrical field as you measure it around that dipole that you just don't flip the thing over. It changes the waveform configuration, therefore where the peak occurs. And I think that's my last slide.
By the way, there is some, in the past also, there's some discussion about some of that cortical potential, the early phase.
Well, let me just say a few words first to the vast audience here. I'm going to sit. I think that's acceptable, isn't it? It's kind of an informal, with only two people in the audience, officially in the audience. I can sit. I believe that the use of dermatomal somatosensory evoked potentials in evaluating folks at risk or clinically suspected of having spinal stenosis, lumbar stenosis, is analogous to the use of median nerve conductions in the median nerve in carpal tunnel syndrome. Prior to Dr. Ian Simpson's paper on the value of doing median nerve conduction studies in patients with what they called at that time acroparesthesia, there were a number of speculations as to what caused this syndrome of hand pain in the median distribution with progressive thenar atrophy and numbness. And Dr. Simpson published a classic landmark article in the British, the Journal of Neurology and Neurosurgery and Psychiatry, about 1957, maybe, something like that. So it goes back 40 years. And he pointed out that these patients had very prolonged conductions from the wrist. He did only motor conductions at that time. That was shortly after the technique of nerve conductions was developed primarily by Lambert and group at the Mayo Clinic, and standards were established. And I remember from reading Simpson's paper, which is, because it's fun to go back and read, I mean, his latencies were something like 14 milliseconds or 18 milliseconds, profoundly abnormal median latencies in these folks. He didn't bother measuring the distance. They were so grossly abnormal that they just stood out. And that was, I thought, a very nice and really the first attempt to take one of these newfangled techniques, nerve conduction studies, and applying it to a kind of mysterious clinical condition and clarifying it. So acroparesthesia became carpal tunnel syndrome. And I would maintain that as research is done in folks with lumbar stenosis, that dermatomal SEPs will have the same value in identifying people who have legitimate neurogenic stenosis from patients who just have referred pain from back pain from degenerative arthritis in the lumbar spine. Please interrupt with questions at any point in time. And the person who is responsible for the technique is not Ed Lambert, but is Jefferson Slimp. And I think that people around the world know that, but maybe people here don't appreciate that it was Jeff and his, how many odd years since you got your PhD? And his PhD, he worked on, it's all he's done in his life is evoke potentials, right, practically, in one form or another. And published his landmark paper in 1992 in EEG and Clinical Nerve Physiology, 92, on the technique of dermatomal SEPs, normal values, and just a wonderful paper with regard to how to do them. And it was Dr. Stoloff, I think, who from the clinical, this was back when I was at Overlake, and a lot of activities going on here, and Stoloff became interested in the problem of stenosis, and Jeff and Stoloff got together, and really they were the ones, the pioneers in this. And what I have passed out today is a chapter I wrote for the clinics, which will really outline what I'm talking about today. A policy paper from the AAEM, which was published in Muscle Nerve about a year ago, in which I've got some handouts there, Michael, in which the applications and indications, places where it's useful are mentioned. And if you look in this under ventral rootlets and roots down under